So today we're talking about glute activation, stretching what's tight, strengthening what's weak.
Yeah.
This old sort of thought process that people have come to. We can start by talking about the articles that you wrote about the fallacy of stretch what's tight.
Like
and
how it evolved.
Strengthen what's weak. And then that also, because people know this model based on the things that they're told about their glutes not firing or their pecs being tight and their traps being weak, and somehow strengthening one side versus the other is going to help.
Right.
People that come to a therapist with a shoulder problem that are told that, oh, well, you have tight pecs and neck muscles in front, so we need to strengthen the back of your body to balance it out.
Sure.
And a lot of that is influenced by some very old neuromuscular work by
Yonda.
Yeah, Yonda, or even back to like Sherrington.
Oh, sure, like reciprocal inhibition and things like that.
Neurological stuff from Sherrington.
But what it is it's the unfortunate reduction of the behavior.
Yeah.
Right? Like it just got reduced over time in an effort to try to make something understandable to someone who may not have a great deal of knowledge. The unfortunate circumstance is that from a practitioner standpoint, that de-evolution also occurred, because it's easy to chunk into pieces. It's easy to teach in pieces. But the result of that is that is then the perception is that you have these individual muscles that can behave separately from everything else, rather than understanding the fact that everything is behavior. Like you cannot do anything with a muscle, right? They are all working together to produce the shape change that is associated with whatever output we create with movement, right? So again, but it's an unfortunate circumstance, because think about it. It's like if I could tell you that, oh, you have a something, like a tight thing or a weak thing, you go, oh, thank goodness. It's like there's a solution for my problem. Right. And it's easy to localize. It's easy to say that this is the problem. It makes me sound really good by saying it. It makes you comfortable to know that, oh, there is a resolution for this, when the reality is it's a lot more complex than that.
Yeah.
And it didn't start out that way. You know, if you look at systems like PNF, where we made reference to Yonda, those are systemic behavioral perspectives that got reduced. So PNF is an entire system, right, that's designed to produce behaviors. So that's why I like it. I don't agree with everything, but I like it a lot because of the way that it's represented. But then that got reduced into isolated stretches, right? Like if you ask somebody about PNF that might be in the fitness realm and maybe doesn't have any sort of advanced education short of their certification or whatever they read, and they will associate that with, oh, that's contract relax stretching, when that is like an infinitesimally small piece of what PNF is as an entire system. Right. And so then that gets reduced, right?
Well,
and then the next thing gets reduced and so on.
Fortunately, I think someone that was writing one of the certification textbooks for, I don't remember which 4-letter certification it was, but I think they decided that PNF was all just like hamstring stretches. And that people got away from that course knowing PNF from that perspective.
Right.
But it's too reduced. And what we had mentioned in the last podcast about motor control and the brain, like having this confusion about the brain not being this master controller of everything. That was also based on a very structurally reductionist approach.
Very much.
Because like what you're saying, trying to explain something to a layman where you're just comparing everything to machines or computers, and these are things that people actually understand. And it's, this part doesn't work. It's not like Legos where this one Lego is there's something going wrong with it, so I'm just going to fix that. And I think originally all of the people that came up with these different schools of thought, the PNF, Cabot-Voss, and forget the third person.
Maybe not.
And even like A.T. Still in the early days of osteopathy, I think he was going after just getting things to move again and making the system move again. Like he would expect it to.
Well, that's how they were identifying ill health.
Yeah,
because
right.
and again, they were looking at it systemically rather than looking at it in pieces and parts. Because what they identified was like, oh, the people that tend to have these aches, these pains, these orthopedic problems, these internal problems,
Yeah.
right? They had a respiratory circulatory model, which was all based on direction and movement. And then they said, well, the exterior movement is associated with all of this other stuff.
Right.
And it's like, so they didn't have x-rays, they didn't have antibiotics, right? So what was the next default? It's like, well, how do you behave?
Yeah.
Right. Movement is behavior. Therefore, it was part of their diagnostic. And so they would try to move things. Like the way that they evaluated was, I mean, it takes some skill over time,
right.
but they were literally inducing behavior. So they would push on you, they would move, they would say this turns this way, and so on and so forth. And they would literally do that structurally. And so that's how they were evaluating people. And they would say, typically, when we see some measure of ill health, we see this behavior, and this behavior. And they were looking at it systemically. They weren't saying that, oh, you have a weak DMO or something like that.
Yeah.
They were looking at, it's like, oh, this is like, there's a series of turns and twists and bends and so forth that we're seeing consistently in the people that complain about, again, some type of an internal problem, whether it be like a GI thing or like, breathing or some other circulatory problem.
You saw that with, I think, the first introduction for that to me was looking at zinc. I think zinc's work. We're talking about the compensatory.
Yeah.
And that was based on what you're saying, just a bunch of osteopaths seeing over the years, seeing the same patterns.
Right. And then to expand on that. So zinc is not the only person that identified that. So there's a Dunnington model, there's a Littlejohn model. They're all similar.
Yeah.
Right, with just slightly different perspectives, or somebody extrapolating further into some area, like looking at the spinal relationship more specifically than another. What's another one? The Kucheras, like the brothers, they were osteopaths as well. So there's a lot of information that is based off of relying on the capacity to identify behavior, looking at things systemically rather than looking at things in isolation. It's like, and we still, like, all of our medical doctors are using a reductionist viewpoint. That's why there's the specificity of medications is the way it is. And then, and there's more and more specific medications, of course, but then of course there's also, secondary consequences associated with all of those. Whereas, if you look at the system as a whole, there tends to be a very strong tension that we need to back up and sort of take the bigger view versus looking at like, take this drug, take this drug, take this drug. It's like, well, how is all this stuff interacting? Like, where's the cascade start, right? And I used to complain about the fact that all I have is movement. It's like, now I'm kind of excited. It's like I have one of the best representations of behavior that there is, regardless of what the problem is. It's like, and I'll give you a quick, for instance, if you have appendicitis, you can't stand up straight.
Yeah.
You have what's called a psoas sign, which means that if you open up that area, there's so much pressure there that it's uncomfortable, and so people will bend over. So literally, you get this broad systemic behavior associated with a localized infection. That's just one simple example, but almost everything is going to have a similar representation. People talk about heart attacks. It's like, well, you get shoulder pain, you get arm pain, you get jaw pain.
Yeah.
It's like there's a referral based, but it is peripheralized, right? It's not just the local structure that's being affected, right? And so again, like, not to poo-poo being restricted movement, because it's actually one of the best representations that we have.
Right. So the shortcomings of the stretch and strengthen model, I don't want to. So there are going to be some aspects of that used as a framework or a tool to evaluate and then even intervene that will help people. But I don't think it's for the reasons that they are saying that it helps, or what people might assume is helping. Because stretching a muscle until you feel tension is actually accomplishing the opposite of what you want.
In a lot of cases, yes.
Yeah. So let's talk about that first, like what stretching really does, end range, long hold, duration stretching, like what that does. And then let's talk about how trying to strengthen an area with resistance and pressure, how that's actually sort of counterproductive in a lot of ways.
Yeah. Well, I mean, if you just let's identify what's actually happening when we're talking about, and we'll make reference to like a typical static stretch of any muscle.
Yeah, I mean, let's use examples of like a pec, let's say like a pec stretch in the door frame, and then doing like a low trap exercise and trying to pair those two, thinking that that's going to fix the shoulder a movement behavior issue.
Yeah. So a couple of things. So the fact that you feel something, so you feel whatever you identify and perceive as a stretch, so that's going to be associated with the tension on the connective tissues, right? And so I could have a difference in muscle orientation and perceive the same thing, right? So then there's no guarantee that like people will say that, oh, you're making a muscle longer. I would respectfully disagree. That's never going to happen in almost every circumstance. You might be applying tension to a connective tissue with the muscle at a longer measurable length relative to another situation, but the sensation is the same. So the sense of tightness is going to be associated with whatever tension is on the connective tissues. So unless you have a way to determine the muscle orientation, you really don't know what you're doing. Like you could literally be yanking on a muscle that is concentrically oriented, actually attempting to resist any movement and perceive the tightness, versus making the assumption that, oh, I'm pulling on it, so therefore it must be longer. It's like, that's not true.
Isn't there literature about adding muscles in series when you stretch it? What do you think they're finding?
Are you talking about like parallel elastic versus series elastic component?
Yeah, like you're actually, I believe it's been a long time since I've been in this research, but they were finding that stretching, what they were looking at was like the series, there's muscle fibers in series, so not in parallel, increasing, like there being some sort of hypertrophy in series.
Oh, you can hypertrophy, sure. Okay, but some of that actually came from a bird study, and then it was extrapolated to humans. So they hung weights on bird wings for extended periods of time, like 20 minutes at a time. Right. And then they saw increase in sarcomeres in series. Right. And so then that gets extrapolated by somebody that probably just read an abstract, right? Not recognizing the fact that, there's methods that were applied here, and it's like, well, it would be unrealistic for a human. Now, there are things like serial casting and splinting, like dynasplints and things like that will hold things at length for extended periods of time. That may produce some measurable effect. But think about how small a sarcomere is. I mean, it's tiny, tiny. Like you would have to add an exceptional number of those to have any effective length change. In most circumstances, number one, you're going to increase the tolerance to the stretch. You could take the connective tissues beyond their elastic region into the plastic region and then permanently lengthen something, which would not be an ideal scenario, because now you've lost the yield to overcome relationship that's associated with energy storage and energy release. You literally have essentially chronically sprained a joint in that scenario, right? Or chronically lengthened in any number of connective tissues. So again, not necessarily ideal. And then again, you have to be careful like where that information comes from, because that, again, applying an animal model that's done in a laboratory setting is usually not a great source of material.
Right. And let's talk about stretching a muscle and the result actually being a shortening of a bone versus the actual length change of a muscle.
Sure. And we'll see this a lot. I think that you will see an emphasis on force production at longer lengths of muscle, or the perceived end ranges of joint motion.
Yeah.
Like you'll see that taught. Right. And I'm not saying it's not useful. I'm just saying that the perception of what's happening is not necessarily the reality, right? Because we do have a skeleton that is also adaptable. A bone will be anywhere from 30 to 40% collagen, which means that it is adaptable. So bones store and release energy just like any other connective tissue. It's just got some other stuff in it that makes us differ. So like the hydroxyapatite makes us differ. But that doesn't mean that there's not a bony shape change, especially when you're talking about some of the extremes. If you look at, like, you take a young, very young athlete and forcibly taking them to the end ranges, holding them there, and this is very uncomfortable, by the way, but you'll see this in some gymnastic realms where they're trying to produce the extremes, or you'll also see it in ballet. Ballet shows, like, you'll see a lot of bony bends associated with ballet, unfortunately, and then there's consequences to that. They can actually perform for a period of time, and then they will actually reach some measure of adaptation where they have compromised their force production and so on and so forth. But to achieve some of the extremes, you have to literally, like, you take where the muscle is attached at, we'll just say it's two ends for the sake of argument, make it really simple. If I have a skeleton that can adapt between those two contacts, if I take it to the end range, the bone can actually compress. That actually provides sort of like a buffer zone that allows a more extreme representation of flexibility to occur, because a muscle is going to elongate somewhere between like 130 to 160% of its resting length. Mm-hmm. And that's a lot, but it's not enough to, like, throw your head behind, or your leg behind your head, or kick yourself in the nose with your knee, kind of a thing. And so you have to account for the shape changes. And so, at some of the extremes, you'll see like a very adaptable spine. You'll see a very adaptable pelvis in like high level gymnasts. They have a very adaptable pelvis, a lot of external rotation within the pelvis itself, along with some of the when you look at the shapes of like a long bone, there's an ER to IR representation in most of the long bones, and you'll see a magnification of that. And that's a twist that actually theoretically shortens the bone, gives the muscle, like, again, the muscles are attached, within those spaces. It's like it gives them more of a buffer zone to actually demonstrate a larger excursion at the joint, because the bones are actually just a little bit shorter in those circumstances, because you're not. It's not a passive muscle. Like, these muscles are like, that's why you feel the tension on the connective tissues. They're producing force. Even in their elongated state, they're still going to produce force at the longest lengths, because the intramuscular pressure, again, increases at the end of that excursion, just like as if you were actively contracting it. So there's a lot of influences when we especially see the extremes of flexibility. It's not just like yanking and pulling on muscles to whatever length that they have the capacity for. It's like you have these adaptations in position, you have adaptations in bony shape changes, and so on, that all contribute, which is, it makes it more interesting for me than just to say, well, obviously we're making a muscle longer, which there's plenty of evidence to show that's not a great representation. You'll see some, small percentage changes that would be associated with really extreme durations of stretching. Right. Magnus, there's one from Magnus in 1996 that they strapped somebody into a little device that kept the muscle elongated, I believe, for 6 minutes at a time. And I think the excursion was somewhere between like 6 to 10%. But even that wasn't retained. Yeah. Like if as soon as you take the stimulus away, it's like, then you don't have that. And some of that's going to be associated with a sensory input. Maybe you get a mechanical influence where some of the connective tissue behavior is changed, but that's not very significant, especially when you're thinking about like some of the extreme ranges that can be demonstrated.
Right. So and that concept can be applied to when you're talking about like shortening of the bones, mm-hmm. and then trying to figure out where you see that, mm-hmm. represented. I think you're going to see it a lot in like when you're talking about having a shorter right leg than a left leg.
Potentially.
Yeah. It's always being, always having that. If you feel tight on that one side, it could just be a result of that, the shortening of the bones and the twisting and turning that's happening.
I would prefer that we say that we're increasing sort of like this differential. Yeah. When you say shorter bone, like the immediate perception for somebody that would be listening to this is like, oh, the bone is just getting, like, right. No,
it's like a towel.
I always use the towel reference. It's like if you twist a towel, the towel just progressively gets shorter because again, you're compressing the towel. That's what we're talking about. It's not an actual, like the limb length will appear to be shorter depending on
But the
and that's
towel is just
also depends on how
twisted.
you measure it. But yeah, it's just a twisted towel.
Yeah. Okay. So then talking about like the opposite end of that, trying to strengthen what's weak. When you do a manual muscle test on a specific set of muscles and you feel a type of weakness, and then we say, okay, well then your pec is tight, and that is reciprocally made your lower traps and rhomboids weak. So we're going to strengthen those. And then they do strengthen it, and then their manual muscle test is better. And maybe their shoulder pain is alleviated. Let's kind of talk through why that might be and what the reality of that versus like then trying to apply that stretch and strengthen model to everything.
Yeah, I mean, it would be great if we could reduce it to that, because that would make life crazy simple. But the reality is that all of the musculature is influencing the shape and therefore the ability to produce force, right? So if we start to look at things as more of rotational versus like a front side, back side, that is a truer representation. Like these helical orientations of like every muscle is going to be helically oriented.
Right.
Especially when you look at the way that they attach to bones and such. And it's like all I have to do is accidentally restore the capacity of the relative motion to allow musculature to participate that was unable to participate before. So if I would just twist your shoulder in a direction, there will be muscles that will gain concentric orientation, and there will be musculature that gains eccentric orientation. So right away everybody goes, oh, stretch, what's the long strength? It's literally not just those two muscles. It's every muscle that would be potentially influencing the control of the shoulder girdle.
Yeah.
Right. They're all going to be participating at different levels because it's a physical shape. Right. And then you did something that changed that shape enough to number one, you biased them by doing a muscle test. So like they're already recruiting other musculature to help stabilize in the second test. So then that confounds the entire test. But let's just say that you did something accidentally that actually reduced some measure of concentric orientation in some area that was potentially preventing another muscle from having maximum force production.
Yeah.
Right. We see this. You'll see this a lot, like a Trendelenburg gait or something like that. And what a Trendelenburg gait is an attempt to push down to create force into the ground in an externally rotated position. Well, an externally rotated position is not a force producing position, right? It's a force reducing position. And then we would actually see an expression of velocity, would be more likely to see velocity in ER. If I push into the ground in that position, there is a collapse. Right, there's a physical shape change that will collapse you towards the ground because you cannot stabilize, you cannot control the position of the pelvis as you're pushing down into the ground. Well, that will get branded as a weak gluteus medius.
Yeah.
When the reality is, it's like, oh, all I had to do was increase the amount of internal rotation through the system, which changes the shape of the pelvis, reorients the extremity, and then I got this high force producing position that would make it appear that the gluteus medius is now strong.
Yeah.
When there was nothing wrong with the muscle before, it's just the position that it was in based on the rotation made it ineffective. And I'm not talking about one muscle, because we would have to have the outlet position, we would have to have the posterior hip musculature, the anterior hip musculature, all contributing to that shape change that actually produces the higher force producing position.
Right.
So it's not one thing, but because in some situations you can do the right thing and you get the desired return. So immediately, and you kind of talked about this today when we were talking about outcomes, it's like, okay, I got the desired outcome, so I must have done the right thing. So therefore, my model is correct that it was a weak gluteus medius.
Yeah.
So there's the association. So there's the progressive reduction over time. It's like if there's enough successes that people identify these things as a reductionist representation versus recognizing the fact that this is all systemic.
Sure. And I think it's a lot about shape change we've talked about, but why the shape change is because of internal and external forces, gravity specifically, structure of the organs, how we breathe, how fluids move through the body. All of these things together are contributing to moving of my center of gravity and where I hold myself in space.
Right.
That is going to force us to change shape just based on how the muscles will have to interact with the body in that position within their base of support or outside their base of support. So that's going to be what ends up having a muscle where you mentioned eccentric orientation and concentric orientation. Let's go back to that a little bit, because I think when we're talking about the shape of someone's pelvis actually decreasing from anterior to posterior, or the shape of someone's rib cage doing that, that will actually change the leverage might not be a good word, but it will actually change the behavior of muscles that are attached to certain areas.
Absolutely.
And let's actually talk about that. Let's talk about someone that's really far forward within their base of support. They're all the way over to the right. Why might someone's glute medius test weak based on that shape?
Literally because of the relationships and then the orientation of the musculature, that based on the direction that you're applying a force.
Yeah.
Then it's like, so you're literally putting all of the tissues. We can't look at this in isolation, and again, this is why the reductionist view comes, because my intention is it's glute medius. I say it's glute medius because of the muscle test that I did, when the reality is like all of that musculature that's surrounding that area is altered in position. So it all matters, right? But again, it's like, but what if you do something to try to change that, and then you don't get the right return? Then what are you going to blame, right?
Right.
When the reality is, it's like, oh, it's the shape change that matters. It's the fact that, so if I compress a pelvis front to back, I immediately reduce its force producing capability. Right, which means that then I have to compensate. So now I'm going to change the actual orientation of the pelvis. So we would look at this from an anteriorly oriented position, because if I compress the pelvis A to P and I actually spread out sideways, I'm reducing my capacity to push into the ground. So I have to push in the ground by changing the orientation. So that changes the spinal position. That's going to change more musculature as far as the position is concerned. Right. And then this cascade of events occurs. Depending on your isolationist or reductionist perspective, you will pick out a muscle that can't produce force in that position. And I can assure you with great confidence that it is, if you were to look at these as isolated muscles, there would be numerous, not one. But in that scenario, people would say, oh, you have weak abs and weak glutes, or
tight low back,
tight low back, and that is a de-evolution from Yonda.
Yeah,
like that's like straight out
it's
of
the
Yonda.
upper lower cross.
That's a misinterpretation of because I think you would see like they would use terms like, oh, it's locked short or locked long. Right. Mm-hmm. And again, that would be an inaccurate representation.
Sure, because that is, you're looking at a resultant behavior based on where someone's being shoved in space.
Yeah.
And then the AP compression you're talking about in the pelvis is actually going to change the orientation of where the hip sockets go.
Correct.
That's why you're talking about having anteriorly orienting as a strategy to help point the hip sockets more towards where they need to push.
It's literally to create a down force.
So I'm changing. If everything's out really wide, I have to orient it to try to get things back down and in
to push down.
And it's where that then you end up creating internal rotation in an externally rotated position.
Right. It's compensatory internal rotation. So now, instead of having the energy that we absorb and then utilize for movement, now you get focal local pressures and tensions, because we get what it's called stagnation. So when energy can't flow through a system and it accumulates in a specific area, that's what we would call stagnation. So imagine it like hitting the knee in the same place over and over again. Yeah. It's like having a little brother that is poking you 1,000 times in the arm. It's like one poke isn't going to do it, two pokes isn't going to do it. But if he pokes you, 2,000 times, it's going to start to bug you. And that's where a lot of these complaints will come from, is the fact that, okay, so I have attempted to control my position in space. I've had to utilize some sort of compensatory strategy. I will orient my body that will reduce the options that I have available, right? And then some people will perceive this as like, oh, it's a tight muscle or it's a weak muscle, when it's really a systemic position. It's a physical shape that the entire system has to assume to control their position in space.
Right. So they're looking at these things that are a result of the shape change.
Yes.
And not necessarily the cause of.
Right. All the muscles contribute to the entire shape. And again, this is why we need to get away from this isolationist perspective, because again, nobody, like if you're successful, it just reinforces a bad model. If you're not successful, then you're going to go, oh, it must be another type muscle, instead of looking at this from a systemic perspective, looking at the associated shapes that we assume very specifically as we move through space in contact with the medium. It's like there's certain strategies that we use to absorb energy, or certain shapes and positions we use to stop, and there's certain shapes that we use to actually produce higher velocities, higher forces. And again, they have to be systemic. They can't be isolated.
Okay, so we're gonna play one of the games I like to play with, counterfactuals, where we're gonna talk about the reasons why, because people are going to listen to this that have already come to their conclusions, and they're going to say, I've been doing glute bridges and couch stretches for hip flexors with people for years, and it gets rid of their back pain. So you're going to tell me now that like I'm not doing what I think I'm doing? Short answer to that is yes. But what we're going to try to do is offer reasons why stuff like that might work. Why might a hip flexor or a quad stretch in a side lying position actually loosen up the area or create more range of motion in an area? Why might your classic side lying shoulder resistance training work?
Well, okay,
it's just based
on for the same reason that it fails, because it doesn't do what you ask it to do. Okay, so here's I will offer you a perspective that might answer the question when you brought up the rotator cuffy thing.
Yeah.
So the perception is that the humerus is moving.
Right.
Okay. What if we expand that to understand that, okay, the scapula is actually moving relative to the humerus?
Yeah.
What if, because I'm on my side and because I have to breathe as I'm doing this exercise, so what if I expand the thorax anterior to posterior? I actually gain relative motions in a joint that didn't have relative motions before, and it has nothing to do with the capacity to increase the force production of a muscle.
Right.
What I did is I increased my overall capacity for force production, and I gained relative movement in the process. Therefore, my symptom is improved. So let's stop blaming the rotator cuff. Let's look at the mechanical relationship and say, well, what is missing? Now, and let's do the exact same exercise. Somebody walks in with the exact same diagnosis. They might even have the exact same measures. I do the exact same exercise and nothing good happens.
Yeah.
Now you have to explain that one to me, right? Because if you're going to say that, oh, it's going to be good for this, it's like, well, why isn't it good every time?
Well, the answer would probably be along the lines of there's too much compression in that person. So even if you put them inside lying, there's no resolution of the A to P
But
dimension.
From a reductionist perspective is what is my point. It's like, okay, if this exercise is good for X, shoulder impingement, okay, why isn't it good for every shoulder impingement? Why don't I get the same result every time? And I'm not saying that I get the same result every time I do an activity, but what we can do, because we've got a more extensive, more reality-based model, is we can look at this thing by reverse engineering, and we can say, oh, it's more likely that this is what's happening. This is why we didn't get the response, because we have measures that are related to the changes that we're trying to be associated with, versus just doing some sort of isolative force producing thing. And again, the muscle tests that I was taught in school create a bias. Like if you ever muscle test somebody and they test weak and you immediately go back after that, it's better. It's like, so what did you do? I induced a reorganization of that system to stop that motion from occurring. That doesn't make it better. That doesn't guarantee that I have successfully resolved something. It just means that I changed the system enough that I get a different response. It's still my responsibility to determine what that different response is.
Yeah.
Right. Because just because they can resist me now doesn't mean that that's the favorable response. It just means they figured out a way to not move.
Right. So so the same thing would be true for, let's take a half kneeling position, like where you would traditionally stretch your hip flexor. Okay. Acquiring that position for anyone will put you closer to, probably not get you there, but will put you closer to, based on your archetype, of course, an internally rotated position at the pelvis.
Okay, so to create the orthogonal relationship, very few people can assume that position.
Sure, but you can get closer to it.
So the closer I get to the orthogonal, the more internal rotation would be represented. The more internal rotation that's represented, that means that the pelvis would actually change its physical shape and its orientation, which means the muscle orientation that surrounds the pelvis would also have to change its position. Right. Not in isolation. Every muscle that's associated with it would change its orientation. I've also changed the force producing capability of the entire system under that circumstance. And I've also increased my ability to push straight down without a compensatory strategy, which is what that sensation that you get when your hips are tight that's what that is. It's associated with the orientation and then the changes of all of the musculature. Right.
Sure. It's sort of allowing you to distribute the forces better, so you don't get as much of that focal local sensation anymore.
Correct.
So that's kind of a brief answer for why a traditional hip flexor stretch in half kneeling might help you feel better. And then you test your glute strength manual tests better, your perception of hip flexor tightness and low back tightness dissipates. Right. And then you're going to say, oh, well, everyone's getting hip flexor stretches now.
Okay. Yeah. Okay.
Yeah.
Now
that's the
okay.
fallacy.
Let me give you another scenario that looks exactly the same.
Sure.
With a different outcome, but the same perceived outcome.
Yeah.
Okay. So I put you in half kneeling. Mm-hmm. Okay. For the same reasons that whatever it's the stretch and strengthen thing. Yeah. Okay. So I put you in half kneeling. Okay. In this scenario, I don't acquire the IR bias.
Right.
That would resolve this. However, I increase the ER bias. Okay. So what this is called, it's called a containment strategy. So it's an expansion of the same strategy that you just had. So it actually creates a buffer by turning you and expanding you farther into external rotation.
Right.
So theoretically, you made more space to move into that you weren't using before. Okay. Mm-hmm. And so because I have now, again, I've expanded where I can move. So the reason that you felt the tension before is like you hit a constraint. What I do is I change the shape of the constraint farther in the direction that has already changed. I create a buffer zone that temporarily gives me more space to move into.
Right.
So it feels better right away.
And these are the people, when you put them in half kneeling, they are on the outside of their front foot, and their back foot is.
You'll see their pelvis is tilted up.
Their back foot is turned. Their back foot is turned. They're almost on the outside of their bottom knee, and their hips, like Bill is mentioning, the front knee side is going to be like way higher than the other one. So they've shoved themselves into even more of an ER orientation to acquire a position that, to an untrained eye, looks right.
Sure.
Because you just measuring this like strange 90 at the knees, 90 at the hips, looks good. And what we're saying is sometimes people will self-organize given enough time in that position to get to that orthogonal IR pelvic position or closer to it. It's very hard to.
I can temporarily create a pathway for the energy that was stagnating in one area. So it's stagnating in the low back or it's stagnating at the hip. Yeah. And I magnify the compensatory strategy. Temporarily, I have now created a pathway for that energy to no longer be stagnated. Therefore, the original pain that I was feeling, I no longer feel because it's no longer accumulating.
Right.
Like I don't have an overload in a situation. I have created, but now this is what we call a misdirection. So this is a misdirection of energy that will eventually hit another constraint, and I will get a recurrence. And so if you've ever done some form of like a stretch or an isolated kind of a thing, and you do feel better, and then you leave the room, right? Yeah. Or you walk out to your car and the symptom is back by the time you get there, or it returns very, very quickly, like within a short period of time. That's what you're looking at. Yeah. See, that was not an effective change. That was not an effective activity. What it did is it promoted a change that redirects the energy that would naturally stagnate in a limited position. You expanded the position temporarily. Energy flows, doesn't hurt anymore. Great, way to go, me. Pat myself on the back. But we talk about signal versus noise all the time.
Yeah,
that's noise. A signal is reproducible over and over and over again. It's not reproducible one time and then it disappears.
Yeah.
And that's huge.
And I think,
And that would be one of the frames of reference that we need to understand is like when I am truly successful in an intervention, it is expressed across a number of contexts. It is not just one, and it holds its position.
Right. It doesn't require like constant management. So I think people fall into certain rabbit holes, and they are trying to. I think a lot of us are trying to accomplish the same things. We're trying to get the whole system to be able to turn to the left again, to be able to turn both ways without this.
I don't think that makes them bad people.
I don't think so either. But I think it's like if I simplify that and reduce it and just say, okay, you stand a lot on your right leg, we're going to have you stand on your left leg and shift everything to the left. I can get you there, and there might be some symptomatic relief. But what you're saying is that all I've really done is I've redirected a movement behavior somewhere else
temporarily.
And in a lot of cases, someone might be able to hang on to that for the rest of their lives, like,
I don't know.
And without any sort of failure. But in some cases,
but you're not going to know why.
Yeah, and it's a matter of right. It's a matter of trying to like appreciate the perspective that that is repeatable, I guess.
Yes, it should be. It should be reversible.
Yeah,
and it should be repeatable.
Right.
And those are two qualities that we look for when we actually truly identify an effective intervention.
Right. Yeah, because if you always have a patient or a client who is great with you in the clinic or in the gym, and they always revert when they leave, and they come back with the same problem, and you fix it in the gym, and then they go out again, you're providing a strategy that is not that. You're not providing them with a strategy that's, and it's probably it's less useful, and probably I would say incorrect or wrong, but that's not really the best way to put it. But it's not representative of what
it's misleading of what the actual outcome represents.
Sure.
Right. Yeah. I think everybody's intentions are honorable until shown otherwise. But again, and I'm not saying this is easy. I'm not saying that it's easy to understand.
Right.
It's like, don't default to something that seems easy to understand and then just accept it because it is seemingly understandable.
Right. Or it seems to work most of the time, so I'm just going to stick with it.
Well, but again, even most of the time is going to be like, I don't think it's going to be a most of the time, unfortunately.
Yeah.
Right. It's going to be enough. Right. It's like, oh, I got to be successful 30% of the time. It's like, okay, if you're willing to accept that, okay, then so be it. And then, your clients are going to have to accept that as well.
Yeah. So I think another example I think that's really useful is because when you consider how strong of a topic and a voice the whole glute activation thing had, it still does. Yeah. Like I was hearing about this in the early, I should say later 2005, 2008 type of time period. That was when I think it really started picking up steam. But the activities that people utilize for glute activation are also activities where you position the shape of the skeleton in order for that musculature to work appropriately. So like if I'm in quadruped and I'm extending my leg, I've achieved a shape that's more conducive to
force production.
Potentially,
yes. Potentially, yes.
Or better yet, if I've given someone a glute bridge, I've actually unweighted one of the areas that was experiencing a lot of volume or pressure differential that I've now changed because I've changed the weight distribution.
Or rather than looking at it from like a singular muscle force production, you actually produce more systemic internal rotation, which allows you to push down into the ground.
Yeah.
Right. With again, you're just creating pressure gradients. Right. In most circumstances. If I can't resist the downward gradient, I will lose every time. I will increase pressure in certain areas. If I can literally lift myself up, I can push myself into the ground, and I can create an internal gradient that resists the downward gradient. Guess what? That increases my ability to jump higher, run faster. It will reduce the stagnation of energy at the ankle, at the knee, at the hip, in the back, in the shoulder.
Yeah.
Right. Because again, I have to be able to hold myself up against gravity. Right. In all of those situations. Right. And so it just becomes part of the solution. But again, I think the biggest argument that we're trying to make here is it's a matter of perspective. And if you can alter that perspective to something that's much closer to reality, your success will increase. Right. Because I think, like I said, I think everybody's intentions are honorable. They just they either haven't invested sufficiently to expand their perspective. They've had enough success. They're nice people like them. And so then, they become professionally successful, whether they are actually successful in the gym. And it's like, it doesn't hurt bad enough to do anything about it.
And I think also
they don't feel like they need to fix it.
People take this sort of shotgun approach and they do 40 things in a session and 8 of them are useful.
Yeah.
And those 8 things are done really well to the point that it sort of counteracts the interference from the others. I think that happens a lot. I think that happens a lot as well. And it's having a model that you're actually looking at these things from that. It's that ability to like zoom out and zoom in with ease. And it also helps you not have to rely on these same things that you're going to do.
And we will all get biased by our clientele.
Yeah, absolutely.
Right. The more complex your clientele becomes, the deeper the representation that you need. Which, again, from a superficial perspective, you get people that come from an active lifestyle. They have, minimal limitations in their current capacity. They have numerous options. There's so much you can do with those people. And I hesitate to use the phrase, it doesn't matter, but you have so many more windows of opportunity. You have so much more space to do things before you would see like any sort of systemic behavioral drift that would actually represent a problem.
Yeah. Because your window of opportunity to put force into the ground narrows. And
so if that's my
shrinks.
Clientele, like on a broad scale, I don't have too many problems. And it seems like everything that I do is okay.
Yeah.
But again, I always have to speak from my bias that the people that I work with have complex problems.
Right.
Right. And I can't rely on an overly reductionist, overly simplistic, isolation, stretch this, strengthen that representation, because it will fail 99 times out of 100.
Right, because you can't use an exercise with everyone. If someone has lost, so if we're talking about base of support being the circle on the ground, they're just slowly losing it in all directions, compressing front to back, getting smaller and smaller, moving over to one side until eventually it's next to nothing, and then you have to step outside of that tiny space in order to do anything.
Right.
I can't just give that person a low trap exercise and hope that strengthening that is going to help their shoulder. I have to actually walk back that compensatory path, give them the space and the options again, and then that's my starting point.
Correct.
And in many cases, you might have changes and constraints that don't allow you to ever get back to that main starting point. So you might always be dealing with that tiny space over the right foot.
Yeah, so like we see a permanent change in a joint.
Yeah.
Right. Like an arthritic change would reduce the amount of space in the joint, which reduces the options that are available.
Sure.
Right?
Or
and there may
hardware.
There may be a strategy that temporarily provides, it provides a space away from the previous space. Symptomatically seems to work, but now you've also eliminated another option.
There's a trade-off.
Yeah, there's always a trade-off. There's always a trade in everything. It's just that the trade-off might be really, really small in one circumstance or really, really big in another circumstance. Right. And this is what we're talking about drift. It's like people change gradually over time, and they literally hold on to most of all of the good stuff until they literally hit a threshold. So the threshold would be like an energetic threshold, which we talk about the ability to absorb and release energy. So there's a point where that becomes compromised. There's a point where the structure becomes compromised. There's a point where if I don't have the tissue adaptability anymore, then gravity is going to win.
Yeah.
It's going to gravity is going to shove you harder and harder into the ground, or you're going to assume a shape that does so you can actually hold your position in space. And that creates a lot of problems. And all you got to do, if you don't believe me, all you got to do is go to the nursing home and you look at anybody over the age of 75 that's walking around, and you will see the effects of prolonged exposures to gravity because they can't hide it anymore. Yeah.
I think we've talked enough about this.
We talked a long time.
Yeah. I don't even know what. What was I going to say? Do you remember like the first book you read?
Curious George.
Okay. That was, which one? I mean, there's so many.
The one that comes to mind was when Curious George smelled the ether and fell asleep.
Yeah.
So he was huffing.
Yeah, he was huffing.
He was huffing. The man in the yellow hat comes to the rescue.
Right.
Yes.
Yeah, that was always an interesting relationship.
Don't ask me why that one pops into my head, but that's the first one that I really strongly. Yeah. Curious George was the whole series.
Dr. Seuss wasn't out. He wasn't around yet, right?
Oh yeah.
Was he?
Yeah, I'm not that old.
Was it 70s and 80s? or was it earlier?
That's a good question. I don't know.
Yeah.
I don't know exactly when that would have
That
come about.
the first book I think I read on my own was Fox and Socks.
Oh, nice.
And I believe I read Green Eggs and Ham to like my mom and sister. My son loves Green Eggs and Ham.
Yes, it is also a great book.
Yeah,
yes, yeah, but without question.
So if you
Curious George,
you remember what
my mom would remember that because I made her read the Curious George books.
If you remember your first book, you can put it in the comment section.
There you go.